Welcome back, everyone. Today, we're stepping up to the whiteboard for a really crucial clinical deep dive. We are unpacking the exact cellular mechanics and the clinical timelines of muscular dystrophy. By the time we wrap up this explainer, you're going to be completely prepared to recognize and confidently manage this condition in your clinical practice. So let's just jump right in.
Here's our roadmap for today. We'll trace the genetic origins, see exactly how it physically presents in our pediatric patients, compare the Duchenne and Becker types, and finally, lock down the diagnostics and treatments.
All right, part one, genetics and pathophysiology. Let's establish exactly what's happening at the microscopic cellular level.
So muscular dystrophy, or MD, isn't just one single disease, right? It's actually a whole group of inherited disorders. And what they do is cause this progressive degeneration of symmetric skeletal muscle groups. In the Duchenne and Becker type specifically, the root of the problem is this devastating genetic mutation. It leads to either a severe deficiency or totally abnormal production of a super important protein called dystrophin. And without dystrophin, the muscle structure simply cannot hold up. Let's sketch out how this is passed down. It's an X-linked recessive disorder, which means it primarily affects males, while females can act as carriers for the gene. Now, what's absolutely critical to note here is the screening timeline. We evaluate this genetic risk prenatally, usually through chorionic villus sampling at around 10 to 12 weeks, or an amniocentesis at 15 to 18 weeks. You see, this isn't just a routine test we run on every newborn. It's targeted prenatal testing for families that have a known genetic risk. Now, you really need to grasp how this degeneration actually works in the body. The muscle cells don't just magically disappear. Instead, as the muscle fibers aggressively break down, they're progressively replaced by fat and connective tissue. Think of it like a thick, strong rubber band being slowly swapped out for a rigid, weak piece of string. As the child grows, their body gets progressively weaker because that functional, contracting tissue is literally just gone.
Okay, moving on to part two, identifying hallmark manifestations. Let's look at how this cellular defect actually shows up in a child. Take a look at this do not miss checklist. If you picture this clinical presentation in a young boy, the weakness almost always begins in the lower extremities first. And that's the domino that triggers everything else. You'll see frequent falls, a very distinct waddling or unsteady gait, and noticeably delayed motor milestones. Honestly, parents will usually bring their kid in because they just aren't keeping up physically with their friends on the playground.
And that brings us to one of the most famous clinical indicators you will ever see, Gowers' sign. Let's break down the mechanics here step by step. First, there's severe weakness in the hip and proximal lower extremity muscles, which means the kid can't just stand up normally from the floor. So step two, they have to use their arms and hands, pressing them hard against their own thighs. Then step three, they literally walk their hands up their own legs to push their trunk upright. They are manually pushing their body weight up because their legs simply can't generate the force.
I really want to hammer this point home for your clinical reasoning. Gowers' sign is a purely mechanical compensation for severe muscle weakness. It is absolutely never a balance exercise. It's not a behavioral habit, it's not a stretching routine, and it's definitely not just simple clumsiness. When you see a child doing this, you are looking at profound proximal muscle weakness, plain and simple. Another thing you'll physically observe is calf pseudohypertrophy. Let's break that word down. Pseudo meaning false, and hypertrophy meaning growth. So it looks like the child has incredibly well-developed muscular calves, but guys, it's a false enlargement. It is actually that exact fatty replacement process we mapped out earlier. The dying muscle tissue is just being packed full of fat and connective tissue.
That brings us to section 3. Let's draw a line down the middle of our whiteboard and directly compare the two major types of MD we're looking at today, Duchenne and Becker.
There is a really stark clinical contrast between these two. Duchenne, or DMD, is the most common, and it has a much earlier onset. We're talking around 3 to 5 years old. It's aggressive and rapid, usually stripping a child of their ability to walk by the time they're 12. On the flip side, Becker, or BMD, has a later onset and a significantly slower clinical progression. This means their ambulatory period, the time they can still walk, is much, much longer. Let's transition to part 4, diagnostics and life expectancy. We need to tackle how we test for this, and a pretty glaring discrepancy you might see in your textbooks.
Let's look at the biochemical sequence first. As those muscle fibers break down, intracellular enzymes like creatine kinase, or CK, leak out and just spike in the bloodstream. And here is the truly fascinating part. This elevated CK occurs way before obvious clinical weakness even appears. The cellular breakdown is happening before our eyes can even catch it.
So this elevated CK is a massive red flag that prompts us to do confirmatory genetic testing, like a PCR, to nail down the exact dystrophin mutation. Now here is a massive source wording flag to watch out for when you're reviewing your materials. One textbook might state that the Duchenne life expectancy is around 30 years. But then your lecture notes might say it's less than 20 years, typically the late teens. That is a pretty glaring contradiction in the literature, right?
So, how do we handle this as clinicians? Well, we aren't going to treat one number as absolutely more correct than the other. What you must grasp, the absolute core medical reality here, is that both figures are describing a serious, relentlessly progressive, life-limiting condition. The end stage is ultimately driven by major respiratory and cardiac decline, and that underlying concept holds true regardless of which exact number you happen to read. Now contrast that devastating timeline with Becker muscular dystrophy. Because of that much slower progression we talked about, patients with BMD can have a life expectancy reaching well into their 50s. It's still a progressive, serious disease, but the timeline is vastly different. Finally, Section 5, Treatments and Patient Care. Let's map out how our interprofessional team manages all of this. As it stands right now, there is unfortunately no cure. So care relies heavily on an interprofessional approach focused on intense symptom management. We use corticosteroid therapy, specifically prednisone, to help maintain their muscle strength for as long as possible. But there is definitely hope on the horizon. We now have an FDA-approved gene therapy, delandistrogene moxeparvovec, specifically designed for children with the DMD gene mutation. It's an absolutely huge step forward for disease-modifying treatment. And notice the red siren here. This alerts us to a really critical clinical warning. If these pediatric patients ever need to go under for surgery, they carry a severe risk of malignant hyperthermia when they're exposed to certain anesthetic agents. This is an absolute do not miss for the surgical and anesthesia teams. I'm going to leave you with this final thought to erase from the whiteboard today. As pediatric professionals, how can we balance the intense, progressive clinical management of these neuromuscular conditions with delivering culturally sensitive, compassionate education to the families navigating it? Because, treating the physical disease is really only half the battle. Supporting the family through it is just as crucial. Think about that as you review your notes. Thanks for joining me for this explainer, and I'll catch you next time.